So in today's session, we'll start with chapter 3 on page number 51 onwards. Feeding for low birth weight and preterm babies. Those who are joining late, please help them out with the page numbers. So the incidence of low birth weight babies in India in the year 2005 was around 30% of all the births that takes place throughout the country. But now it is much better. It is below 20% in most of the Indian states, but some rural states, some backward states, it is still 30% or more. Okay. So the main issue with feeding, feeding related issues that we see in low birth weight babies as well as preterm babies is the absence of sucking or swallowing, or it is not, the latch is not as strong. Okay. By the age of 34 weeks, sucking and swallowing becomes coordinated. Preterm babies who are born before 34 weeks, this coordination is not that, because of which there could be certain difficulty in feeding. In low birth weight babies also, certain degree of lack of coordination between sucking and swallowing is seen. Okay. But the growth velocity, the pace at which the low birth weight babies grow, okay, that is much higher than preterm babies. Preterm babies will take much more time to catch up with the growth. But low birth weight babies, if they are fed well, if the nutrition is given to them properly soon after birth, the growth velocity, the way how they grow and pass up, the how the pace of growth increases to catch up with their peers, it is much higher as and faster as compared to preterm babies. But the nutritional stores in the low budget babies are quite less. The way how the body is able to store onto nutrient for a longer period of time is quite less. They are born with inadequate iron supplies as well. Okay, so by the age of 2 month year old, that at that particular age onwards, iron supplementation may also have to be started. We will see that later. Gut maturation is adequate. They are able to successfully digest the breast milk, the proteins and the fat in breast milk, as well as lactose in breast milk or other formula feed, if it is prescribed, is successfully digested. Gut maturation is adequate in low birth weight babies, but it is inadequate in preterm babies. In majority of the preterm babies, gut maturation is inadequate. Minimal enteral feeding should be given. Otherwise, whenever possible, enteral feeding means through oral feeding of breast milk, either through breastfeeding, expressed milk, nipple feeding, pallida feeding, cabbage feeding. Okay, any form of enteral feeding should be continued whenever possible, because it will make sure that the gut hormones are being released, the enzymes, the digestive juices, etc., are being released. If you put the child always on parenteral feeding, that is through IV fluids and all, okay, it will suppress the gut hormones, the gut enzymes, digestive juices. So to keep the gut healthy, to keep the gut matured, minimal amount of enteral feeding is required. Wherever it is feasible, it has to be followed. The RDA that we use even in India for feeding the low birth weight babies is based on the SCAN, that is European Society of Pediatric Gastroenterology and Nutrition. What they have provided is what we, even in India, that is what we use. So these are the recommendations given by the SCAN. Protein, 4 gram per kg is recommended. Whatever is the weight of the child, 4 gram per kg on a daily basis is recommended. If at all you're giving them higher dose, it can lead to hypoglycemia, hyperaminoacidemia, too much of amino acids in the blood. Okay, tyrosinemia, any metabolic acidosis can take place. So to prevent that, limit the protein intake to just 4 gram per kg. This is given when you calculate the pallida feeding or by prescription, whenever the doctor is prescribing this amount of breast milk or this amount of formula of milk at regular interval has to be given. You just have to follow it. Fat, fat malabsorption and steatorrhea is commonly seen in preterm. Steatorrhea is too much of fat molecules in the defecation, in the feces. Okay, so and it can after a certain age, after crossing certain weeks of age, it can come back to normal. Bile salt stimulated lipase that is present in the human milk is able to help in fat absorption. So if the child is not put on human breast milk, there are chances that the child will suffer from fat malabsorption. If the fat is not absorbed properly in intestine, automatically it will be lost through feces. Even the long chain polyunsaturated fatty acids and the omega-3 fatty acids which are present. Just give me a moment. Yeah. So the presence of the specific long chain polyunsaturated fatty acids and the 8% linoleic acid in the human milk, human breast milk are are helpful, create a helpful environment for the absorption of fat from the intestine. It also contains adequate amount of carnitine, choline, medium chain triglycerides. Okay, these are in adequate amount. What is required for the whatever amount of maturation the baby's gut has. Okay, so based on that requirement, human breast milk can fulfill the requirements of fat absorption as well. Coming to carbohydrates, the presence of lactose, which is lactose is in quite high amount in the breast milk as compared to other form of milks. So the presence of lactose enhances the absorption of calcium and magnesium. But if at all the premature infant is lactose intolerant or is born with certain metabolic errors, in that case, it could too much of lactose through even through breast milk can lead to osmotic diarrhea. And that is the reason why in certain formula feeds, it is preferred that the formula feeds use maltodextrin because maltodextrin is already partially digested glucose. Okay, it's a form of carbohydrate. It is partially digested carbohydrate. So it is much more easier on the child's gut, on the preterm babies or the low birth weight babies' gut. So maltodextrin based formulas are recommended as compared to lactose formulas, specifically in children who are lactose intolerant or born with certain metabolic errors. Energy and fluid requirement 100, 110 to 165 kilocalories per day. The child will be hardly 2 kg, hardly 2 kg. If the child is 2 kg, you do not consider them as low birth weight. But whatever is the weight of the child, 110 to 165 kilocalories per kg per day has to be maintained. Slowly, it can be increased. Slowly, 10 ml per day can be increased. Macrominerals and microminerals. When it comes to macrominerals, if there is a magnesium deficiency, it can lead to calcium hemostasis, low amount of calcium, and hyponatremia. And calcium and phosphorus supplements may be needed to prevent rickets, but not in all case of preterm or low birth weight. Every child does not require calcium and phosphorus supplements. So calcium, if it all it is required, it is given at a dose of 40 mg per kg per day, and a ratio is maintained. Double the amount of calcium should be given as compared to phosphate. When it comes to microminerals, the focus is on iron deficiency. Specifically in preterm babies, iron deficiencies can occur by 6 to 12 weeks. That is around 3 months, iron deficiency can take place. So to prevent that, 2.5 mg of iron per kg per day supplementation has to be given. This The supplementation has to be begun in certain cases. In extremely preterm baby, this has to be started within 2 weeks. And after, if it is a low birth weight babies and all, extremely low birth weight babies and all, from 6 week onwards, this supplementation can be started along with the expressed breast milk. When it comes to vitamins, vitamin K, an injection of vitamin K is given, one dose, 0.5 to 1 mg injection is given. So this can prevent the hemorrhagic disease or any blood loss or bleeding conditions in the newborn babies. Coming to the choice of milk, there are various options apart from the mother's own preterm. There are other options apart from the mother's own preterm milk as well. Okay, preterm milk, preterm milk is found superior as compared to any other choices. Preterm milk should be the first option because that is the one of the best way through which you can get cholesterol. Okay. Other forms of milk that you can choose from is pasteurized donor milk, donor human milk, which is pasteurized, that can be provided to the new low birth weight babies or preterm babies. So preterm milk, the milk of the mother who has just delivered a preterm baby, is the major source of nutrients for all the preterm babies. It is slightly different from term milk, okay, which has a higher concentration of nitrogen and protein. So high protein content reduces to 1.3 gram percentage by 6 weeks. Slowly, the protein content will also reduce from the mother's breast milk. So preterm milk is slightly different than the term milk in terms of protein concentration. Expressed breast milk, next is your expressed breast milk, EBM. It can be either fore milk or hind milk. Fore milk is more watery in nature. It can take care of the thirst of the child. Hind milk is the milk that comes later. It is more rich in fat. It is more creamy. Okay, it can take care of the hunger of the child. Then we have drip breast milk. Drip breast milk is collected from the collateral breast due to the let down reflux of feeding. While the child is being fed on one breast, the other breast also starts secreting milk because of the let down reflex that takes place. So that milk can be collected even without sucking, just by the force of it. Okay, breast milk just drips out of the nipples. Okay, from one breast when the child is being fed, from the other breast the child may from the other breast, even if the child is not attached to it, the other breast may also start oozing milk out. Okay, so that is the drip breast milk that can be collected. Okay, it is very similar to expressed milk. When the pooling of drip breast milk is done, it is very similar to expressed breast milk, but it has more water content. The fat concentration is quite less in drip breast milk. Ordinary or special formula. Infant formulas should contain more proteins, multiple types of carbohydrates, MCT, that is medium chain triglycerides, uh, polyunsaturated fatty acids, okay, long chain polyunsaturated fatty acids. These should be more because it is a source of energy as well as for brain development. DHA also should be present in the formula more minerals and vitamins as compared to routine infant formula. These kind of specific infant formula is selected and it is only prescribed only when it is prescribed by the doctor, then only special formulas should be used. The best choice for premature baby is always the preterm mother's milk. However, if you are able to express the breast milk from the mother, you can fortify it with human milk fortifiers. I'll show you that. So human milk fortifiers can be a milk pool from the mother who has delivered prematurely is one option. And to cut down the volumes of it or to make it more nutrient friendly for the child to have it, as we have mentioned, preterm breast milk is slightly higher in protein content. It lacks other minerals, other aspects. Okay, so just to make it much more beneficial for the child, human milk fortifier is used. Okay, that is in a powder form. Okay, that is added into the expressed breast milk of the mother or the drip breast milk of the mother, and then it is fed to the preterm baby. So this is the drip breast milk, in which you can see the child, preterm babies or the newborn babies, they do not have that sucking and swallowing reflexes which is coordinated. Okay, but the mother may still have the let down reflex. Okay, so here, even without the child is trying to suck on the mother's breast, the milk, because of the let down reflex, the milk is coming out. Okay, so through this also, through this method also, you can feed the child, even if the child is not able to, doesn't have the strength to suck and swallow. Okay, this method can be used. Otherwise, this drip breast milk can be collected in a palada or in a clean hygienic container, and it can be fed to the child in at regular intervals. This is a human milk fortifier, food for special medical purposes only. So it is a dietary management for preterm and low birth weight baby infants, and it should be used only on prescription. Okay, and not without prescription, these things should not be used. So it is this powder, human milk fortifier, is commercially available, and it is added into the expressed breast milk. It contains specific protein and protein hydrolysate also, because protein hydrolysate will make sure that the protein is broken down adequately so that it does not overwhelm the child's immature gut. Because you are feeding this to a preterm baby or a low birth weight baby, so gut maturation could be an issue. Okay, so that is the reason why protein hydrolysate has to be added. It has an adequate amount of fat, carbohydrates, sodium, calcium, phosphorus, copper, zinc, vitamins, etc. required by the child's growth. The quality of the express breast milk completely depends on the time and the mode of collection, at what time it was collected and what was the mode of collection. Next is non-nutritive sucking. So in this, uh, it is used during the gavage feeding and in transition from gavage to breastfeeding. Gavage feeding, I'll show you the image of it. Okay, how gavage feeding is done. It's like an NG tube feeding given to the child, given to a newborn or a low birth weight baby. To breastfeeding in preterm infants. It facilitates the development of sucking behavior, because even if the child is not being attached to the breast or the nipple, if the child is even sucking on its own thumb, on its own hand, okay, the jaw muscles are developing. The jaw is getting stronger and stronger. It is gaining strength to suck and latch on the breast later on. Okay, so this non-nutritive sucking is that in which the baby is sucking on its own hand or its own fingers to practice sucking. Okay, it improves digestion and of enteral feedings as well. While enteral feeding is being done, for example, cabbage feeding is done, the child's through the child's nose, the cabbage feeding is going inside. Okay, but at the same time, encourage the child to suck on its fingers or thumb at the same time when the cabbage feeding is done. So that will make sure that the gastric movement is ongoing, and there is no digestive issues. It may be done with empty breast or with pacifiers as well. If the mother has expressed the breast milk out and the breast is empty, okay, instead of putting the child's own hand on its mouth, it's better to put the child on empty breast. That can also lead to non-nutritive sucking. Or you can use pacifiers, but if you use pacifiers, there are other hazards. The child may get stuck in the oral stage, or the child may reject the breast later on because it is used to the pacifiers, which is similar to bottle feeds. Okay, once the rooting is noted, rooting means when you touch the side of the child's cheek, okay, from the end of the corner of the mouth, when you try to draw a small line towards the cheek of the child will turn its head towards that side wherever you are drawing or wherever you're touching the cheek of the child. That is rooting reflex. Okay. So as soon as these reflexes will come a bit delayed, they will come in a bit delayed form in low birth weight babies and preterm babies. So as soon as the rooting reflex is found in the child, the mother should pump her breast before the skin to skin holding session, because the initial let down reflex can overwhelm the child. Okay, As soon as you see the routine reflex and you put the child on the breast, the initial let down of the milk from the breast may be overwhelming to the child. Okay, the child may do not know what to do with so much of lots of milk at the same time. So first, the mother has to slightly pump her breast, make sure that the flow is ongoing, let down reflex has passed away, and the milk, the flow of the milk is adequate, and the speed of the flow of the milk is adequate enough for the child to latch on to. Okay, so first, before she does a skin to skin folding session, that is kangaroo mother care, she has to pump her breast, little express a little bit milk out, and then put the baby on the breast as soon as the routine reflex is noted. One second. So that was about non-nutritive suckling. Then we have lactobacillus, which these has to be operated usually. Okay, these are milk residues that accumulate in the stomach. It may cause discomfort to the child. You may have to remove it through laparoscopy or through surgery. These will this could happen because if the child is put on any high calorie, too much of lactose based, too much of hydrate based baby formulas. In that case, the child may develop lactobacillus, and it is only you can diagnose it once you do the X-ray of the child. When you do the X-ray of the child, these thick masses are visible in the stomach area, so you can diagnose that it is a lactobacillus. The child is suffering from lactobacillus. It is done by the pediatrician. The diagnosis part is done by the pediatrician. Mother and infant bonding. When the care of the preterm baby is undertaken by a third person, like a nurse, the mother infant bonding reduces. Okay, so you have to try to keep the infant very close to the mother as much as possible soon after birth, because mother is the primary caretaker. Okay, and the mother infant bonding has to be established. Only then the child may feel secure. The child's cognitive and psychological development and emotional cognitive thinking will also develop in this particular stage. Only then the mother's bacteria as well can colonize the child. Otherwise, the child may get fever or get infections from its own mother's body bacteria. Okay. Catch-up growth. In a full-time baby, the catch-up is about 200 grams per week. Every week, 200 gram has to be increased in the weight. And after first 10 days of life, because as soon as the child is born, in the first 10 days, the weight slightly reduces and later it increases. Okay, it happens to all healthy child. And even initially in preterm babies, a slight initial loss of weight is seen and at birth, and this lost weight will be again regained by the 10 days, next 10 days. And then 200 gram per week catch up should be maintained. Warm chain. So warm chain, which means you have to keep the baby always mummified in baby clothes. Do not keep the child without clothes. Uh, Wrapped with head, and head should be also covered, because heat is usually lost from the head. Most majority of the heat is lost from the head. So keep the head covered so the baby is kept warm. Minimize bathing the child, especially in cool weather, and small for gestational babies, preterm babies, low birth weight babies. Try to minimize the bathing schedule. No need to bath the baby on a daily basis. Okay. Keep the baby always very close to the mother. Okay, and encourage kangaroo mother care. Okay, even when the child is discharged from the hospital, KMC has to be encouraged to stabilize the low birth weight babies and to rewarm the stable big babies. Show the mother how to avoid hypothermia by keeping the child always covered in a blanket, always mummified. Okay, how to do the how to wrap the baby. Okay, These things has to be taught to the child and taught to the mother, and she should be always aware of the baby's feet. The baby's feet should always be warm to touch. Baby's head should always be warm to touch. Okay, these two areas should always be kept closed using any baby warmers, soft woolen clothes. So warm chain has to be maintained. Even when the child is robot or baby is being transported from one ward to another, from hospital to home or to hospital to any daycare center, this warm chain has to be ensured. Feeding of low birth weight babies and preterm infant. Exclusive breastfeeding should be done for preterm babies. It is the best option possible, and whenever it is feasible, exclusive breastfeeding has to be initiated. Those children who are not thriving well, means who are not developing well, okay, they will definitely require human milk fortifier, even if it is donor breast milk, or even it is the preterm breast milk or expressed breast milk, okay, pallida feeding, drip breast milk, whatever kind of breast milk you are giving, it will require human milk fortifier, and with along with the combination of human milk fortifier and expressed breast milk, the child has to be fed. And this is only prescribed, only based on prescription, human milk fortifier has to be used, otherwise not. And collection of the milk and mixing the milk, it will require extra care. Do not overdo with the human milk fortifier. Never do that, because it will again put the child on some disconnect. It will make the child discomfortable because of gastric issues. Route of feeding. If the child is about 34 weeks, and the child is weighing more than 1.8 kg in weight, you can directly put the child on the mother's breast, and the child will show sucking and swallowing reflex. Usually after 34 weeks, sucking and swallowing reflex are coordinated well, so the child can be put on breast for breastfeeding. If the child is below 34 weeks and the weight of the child is about 1.5 to 1.8 kg, gavage feed has to be used, and slowly, based on the recommendation of the pediatrician, based on when the pediatrician, the doctor thinks the switch can be made, slowly the switch has to be made to oral feeding. So this is how gavage feeding is done. A feeding tube is inserted through the nose of the baby and directly into the stomach, and this supplies the food. Along with food, medicine, some medication if it is required, that is also supplied to the child. 1 to 2 hourly feeds can be given. 1 to 3 hourly also can be given. It is very subjective based on the child's requirement. For smaller to large babies, you can keep this accuracy. Initial feed should always be colostrum. Do not miss out on colostrum through expressed breast milk. If you find any abdominal distension, because the child's stomach is like a cherry, okay, a newborn baby's stomach is very similar to a cherry. If you overfeed the child, there will be abdominal distension. There could be blood in the stool, so keep an eye out for that. And if at all you understand that your feed volume has to be reduced below the total fluid requirement, IV infusion can be given along with the gavage feeding. With gavage feeding, definitely enteral feeding is practiced, but to make sure that you do not dehydrate the baby, IV fluid can be started. Generally, the children who are babies who are more than 34 weeks, they can directly be put on breastfeeding, or if the child is, even if it is 34 weeks above, but the child does not have a good latch, okay, the child does not coordinate with sucking and swallowing well. In that case, pallida or spoon feeding can be given. I have shown you the image of pallida. This is how this is an aluminium pallida. This is how it looks. Expressed breast milk will be put into this pallida, and it is very easy for the child to consume. Sucking is usually not required here. Swallowing has to be established. The child has to establish swallowing. So that's about feeding of low birth weight babies. If you have any queries here, please mention in the chat box.